Hi everyone, this is Mary Gregory here with MAS Coding Solutions. Wow, we are going to talk about MIs today, myocardial infarctions. That could be a little bit difficult to code. And I want to speak to this subject because recently, within the last maybe 2 years, could have been longer, the OIG, the Office of Inspector General for the Health and Human Services Department, has been looking at about 7 or 8 diagnoses that they feel like got some coding issues. And they looking at their managed care contractor, which is Part D. They did one, I believe, out of Michigan, Blue Cross Blue Shield maybe, and I think they did one out of Texas. Now, they've done more. And they are looking at these diagnoses and finding that there's quite a few errors in the coding of these diagnoses. Well, today we're going to focus on the myocardial infarction. This is one that they are finding that is being coded and the documentation is not supporting a myocardial infarction. And there's a lot of talk about why they think that it's happening, so I'm going to put my 2 cents in there. I think it's happening because we don't understand what the documentation should look like. Now, of course, we're not physicians, and we have to depend on our physician documentation. But we also have to depend on coding guidelines. And what we're finding out is sometimes physician speak or physician talk may not necessarily line up with the coding guidelines. For instance, if you look in your category I-21, if you have your book, which I have my book, you got a category I-21, that's the category for MIs. You can have, there's several different types of MIs. You can have what we call a STEMI MI, and STEMI rules, and you definitely going to have this on the CCS, I can guarantee you this. You have STEMI, S-T-E-M-I, you have a non-STEMI, and you have type 2, you have a type 2 MI. You also can have other types of MIs. You can have a type 3 MI, type 4, I think they got, 4A, 4B, 4C, and type 5. Now, if you want to know a little bit about those types of MIs, go to category I-21A. A is an apple. Now, I won't be able to get into all of it, but the other thing you have to remember too, remember I just made a statement about STEMI rules. If you go to your official coding guidelines, when someone have an MI, if it start out as a non-STEMI and it converts to a STEMI, you have to code it as a STEMI, S-T-E-M-I. So the STEMIs are in category I-21, dot 01 maybe, 02, 09, I-2111, I-2119, so your I-2121 and I-2129. A non-STEMI is really simple to code. You only got one code for a non-STEMI, that's I-21-4. So if your patient starts out having a STEMI, ends up, and it's a STEMI, it's going to be in the I-21.0, I-21.1 category. If your patient start out with a non-STEMI, and the physician document that it becomes a STEMI, you're going to code it as a STEMI. And the non-STEMI can only be coded as a non-STEMI as long as it is a number one, they diagnose it initially as a non-STEMI, and it stays a non-STEMI. That's an I-21.4. But if that non-STEMI converts to a STEMI, you have to code it as a STEMI. Also, your physician may document this, but you can't code it this way. You cannot have a type 2 MI as a STEMI or as a non-STEMI. Now, your physician may document that, but guess what? The coding guideline says that once that patient, if that STEMI is identified as a type 2 MI, then you have to code I-21A, it's an apple, 1. That's the coding guideline. And so and that's a type 2 MI. Remember, your type 1 MIs, your STEMIs and non-STEMIs, are really due to the fact that that patient has some type of ischemic, have some type of structure damage going on in their heart. They may have thrombus, they may have an embolism, they may have coronary artery disease. And remember, your type 2 come from that patient, you got what they call a demand, too much demand is being put on the heart. And you generally see type 2s and maybe patients that, you can see it in a drug abuse patient. You can see it in a patient that have anemia where the hemoglobin get way too low, and now the body is demanding more than oxygen than it can produce, and it can cause that patient to have a type 2 MI. So you have to, usually there's no structural damage when people have a type 2 MI. If you go to a type 2 MI, in your book, it got a code first note. So really they say code first, the underlying condition for the type 2 MI. When someone has a STEMI, it doesn't matter what caused that STEMI. That STEMI can and should be your principal diagnosis. So I just wanted to clarify that, talk to you a little bit about that. The others, recently, what I believe this is 24, in 2023, but you can check me out, because we were having patient that was having some type of, quote, myocardial injuries that wasn't MIs. There was no way to show that. So they gave us this code called I5A. That code says, let's look at that code in your book. I5A. When you go to I5A, it says myocardial injury. Non-ischemic. See, it's non-ischemic myocardial injury. Now, when physicians sometimes talk about an injury to a solid organ, they're not talking about trauma. But what they're saying is, look, that patient had a blood clot or thrombus or something internally damaged that organ. And so they're saying non-ischemic damage will not go to an ischemic damage. The ischemic damage is your MIs. When the physician documented, of course. But non-ischemic myocardial injury goes to I5A. And I didn't write it down. I started to talk about it earlier today. When I was preparing, I thought, okay, I need to talk about this. But then I thought I was going to do something else. But anyway, your troponins, these patients tend to have high troponins, just like an MI, an acute MI. They have high troponins, you know. But one of the key difference with having that high troponin is that in this particular injury, this particular coded scenario, it's not ischemic. It's not due to, to some type of ischemic problem with the heart. Now, also, too, you can have high troponins due to other condition as well. Sometimes patients that have acute renal failure, chronic renal failure, can also have high troponins. And so just because someone have high troponins, troponin, I believe it is, troponins, just because they have that don't mean that they have had an MI. You have to be guided by your documentation. It's so important that you do that. You got to be guided by that, okay? So I just wanted you all to know that today we talked a little bit about myocardial infarctions. Can't get into it really deep like we should or could, but I think this is enough for you to code it accurately. And be aware, especially if you're an HCC coder or inpatient coder, these I-21 versus an I-5A make a tremendous difference in the reimbursement. And that's why the OIG is looking at this diagnosis so closely with the Medicare managed care insurance companies, because they're miscoding this and they get additional. That's a HCC, a very high paying HCC. Well, the I5A may also be a HCC, but guess what? It's not going to be in that high paying. It's not going to be in the high weighted one. Okay, so it's very important that we get this coding correct in dealing with these MIs. And with the MSDRG reimbursement, it's huge. It's a very huge thing. The code, the I-21 versus this I-5A. So hopefully that will help you out on your CCS. I know it will. Ain't no hoping that. I know it will help you out. That definitely going to help you with your inpatient coding. I look forward to talking to you all again in the future. And don't forget to follow me on Facebook, LinkedIn, and now we're on TikTok. Oh, girl, guys and girls, I finally got it done. I'm on TikTok. Pat myself on the back. So follow me on TikTok, and I just look forward to seeing you all in the future. And what else do I need to say? Have a great and wonderful day.